what we're looking for in analytics at my place at our current stage of development is really how do we cope with this payment reform? And really, what that gets down to is how do we support people changing their behavior, right, to deliver what we want to happen. So right there are these traditional ideas about analytics, descriptive, forecasting, predictive, and prescriptive. I consider that prescription being the highest level really comes from the machine kind of companies that are analyzing data coming out of machines like GE, jet aircraft, right? Because in medicine, we have been prescribing for a long time, millennia, right? So our challenge is when we want something done, how do we get it done when we have the wetware to deal with, right? Not the hardware. The wetware is the hardest thing to get to work, the people.
So lean can be used to address specific improvement projects, or it can be used more generally as a management philosophy. And so you can actually differentiate organizations by those that choose to have a set of business practices and then go in and do a lean project, and they apply PDSA cycle, which I'll speak to in a minute, and they do the improvement and then they go out. Or you can adopt lean management at a more theoretical level, and that's what QCH has decided to do. So this involves a huge cultural shift, right? Because we have to teach our frontline staff how to think critically. In a lean system, the commitment starts from the leadership, and it's almost like it flips the whole hierarchy upside down. Because what happens is that the jobs of the leaders now becomes to remove barriers for frontline staff so that they can identify defects and then become empowered to do something about it and not have to go through a huge bureaucratic process. So the people who are actually doing the work, the nurses, the ward aides, the porters, the lab techs, the clerks, we teach them what to do when they find a process that they can improve because they've seen waste of any kind. And then we train them in the PDSA cycle. And then we provide them with the resources, so the time and the coaching to do something about it, to be able to redesign and improve that process.
So I think a key thing is when you have somebody willing to endorse something and willing to endorse change, it's a lot easier, obviously. Because if you're trying to push things uphill, it's really hard. Here's something that I did is I would joke in the company, and you could actually go around, you probably could still go there now, and there's a saying, cash is queen. So at first they were joking, they said, no, cash is king. I said, no. The king may think he's the head of the house, but the queen, she's the neck, and she turns the head any which way she wants. So I got the whole organization understanding that cash is queen. So much so, at one point in time, Ainsworth, a very large company right across Canada, multiple branches, lots of people. So much so, at one point in time, we had the full board in for a meeting, including we had the chairman of OMERS in. And then I was standing up doing a presentation, and it was a town hall, and I said, everybody, I said, you know what my saying is, what is it? And all in unison, and I never coached them, and all in unison they said, cash is queen.
This is my techie part that comes out now, but BestWorks is fantastic because it basically allows to have every other platform, not just BlackBerry, that's also safe and secure now. And so the other really cool thing that they did at General Hospital is that, for me, great IT is seamless IT. And I think that, we also talked about the fact that it's invisible IT, right?
So, well, we want to stress that IT needs to be simple and the privacy and security needs to be invisible.
That's right. So what they did at General Hospital is that they not only have and use BBM protected to communicate with each other, but basically when you go and then you start texting, they basically kind of able to see like who's on call that day. I want a cardiologist, so I can go into the cardiology section and I don't have to befriend, I don't have to friend anyone, I can just select that person and then I can just start texting, or I can voice it on the phone, or I can do a video conferences, or I can take a picture of the wound and send it right away. All of this is done securely, encrypted, we've done TRAs, we've done PRAs, we've done everything to make sure that it is safe and secure.
So you don't need to know who it is that you're looking for. So you can just look up cardiologist and pull up the cardiologist.
And so what's next? And so again, the hospital gave me the okay to talk about that. What's next is to take that information now that it is in the message that's coming across. And so think of consultant time. So I think that anyone who has submitted data to the ministry and tried to find this information, it's very hard to find it into the chart. So now we have, because under BBM, if you have ever used it, it tells you the time it was delivered, the time that it was read, the time that you answer. And so we can all take that data now, either push it to the APR or push it into the data warehouse. At General Hospital, they have the IBI product, and then being able to then took it through Med 2020, submit to CIHI, and then submit to the ministry. So again, you have the data that you need, and this is just one application that what we can do. But again, this is kind of shows us like, okay, it's fine once you have the data, but how do you get the data in the first place? And we're able to do a very much a full integration, right from BBM protected.
Last year, the things that we're doing with technology are really starting to hit home, and it's no longer just a small trend. It's starting to shoot up, and we're going to see more and more of that. The whole idea of e-health, and that's why I'm willing to give up 2 days, really, of my job to be at a conference like this, is because I'm starting to recognize that we've got to get e-health right, and that really holds the future in my mind of where we need to be going in healthcare in this country. We've got challenges with infrastructure. Most of our infrastructures were built in the 50s and the 60s in dire need of repair, update, or even demolition, and we need to do some work there. We have significant funding limitations, and yet our people are very tired of change. We have change fatigue setting into our workforce as our demographic start to get to the point where more people, as we said yesterday, are looking for that retirement, can see it on the horizon, and not so sure they want to juice up to take on that next big change that's coming. We have a lot of pride in the work we've done, the system we've built, and sometimes pride can get in the way of change. Yet, there's optimism of things that are going great in the system. I don't want to paint a picture that, as we say in Newfoundland, the arse is out of it. No, not by a long shot. And so we need to be proud of some of the changes that we're making. But the incremental changes of the past are not enough to deal with the circumstances we're facing. It's not an option, and transformation is needed. And I know even one of the strategic initiatives of our LIN is that they want transformational change. And they stated it quite explicitly. And of course, we all are grounded in the fact that while people may want transformational change, that very few transformational efforts are as successful as people would envision and prefer.
So this is where my clothing is a prop for my presentation, because really benchmarking is about hunting. You have your scope, you set it on where you want to go, you have your percentile that you're aiming for, whether it's a target or aiming for the 100th percentile, and you've got guides that help you understand where you are relative to that target. And really, benchmarking gives you that tool to become very exacting and very deliberate with what you do and how you find opportunities for improvement. It also embeds in those etched reticles, I just learned is what they're called. But they're adjustment factors. So the further out the target is, the more you might have to adjust and accommodate for the distance of that. And so that's what the adjustment factors are there for. And benchmarking is really a tool that helps you in that way to identify what you want to work on.
Managing 10 different managers with slightly variations. So we want to come up with the idea of widget where a user can have their preference and it will automatically populate the values based on their settings. Another thing is that I don't want to create something useless in meaning that no one ever going to use it. So I want to create something valid beautiful and meaningful, right?
For most of the hospitals, if you're in a hospital here, this is becoming a big share of your money. So it's important to kind of understand the context, and then it's important to understand what can I do about it. What I'm here to kind of talk about is what we said, what's within our control, and what's within our ability to sort of focus in on the data and go, are we painting the right picture with all of our data sets? I don't expect everybody to read this at the back of the room, but basically the data goes into the funnel, you sort of have your outputs, but this is the HBAM methodology. One thing I mentioned earlier is I can't know everything, but I sort of have people on my staff that do. I'm sort of privileged that Paul Sandor, he wasn't here yesterday, but he's here with us today, was a big player in actually designing the HBAM model in the province. They've tweaked it since, but it's really helpful to have people on your staff that can really understand this, because this is going to drive, this is where hospitals should be looking to move that sort of needle on their funding.